Thanks for joining us. I know that there are still people logging on, but we're going to get started right on time here to give our speaker plenty of time for her presentation. Thanks for being here and joining us for the University of Washington Center for Child and Family Wellbeing's public lecture with Dr. Christina Bethell, who I'm going to introduce in just a moment. My name is Liliana Langua, and I'm the director of the Center for Child and Family Wellbeing. Our mission is to promote the well-being of children by supporting the social emotional skills, well-being, and mindfulness of the adults in their lives and in the communities around them. One of the ways we accomplish this goal is through this public lectures series, where we share research-based opportunities to support child and family well-being. I'd like to start this afternoon with a land and labor acknowledgement. We ask for those engaging in this event to reflect on the lands on which we reside and acknowledge all of the ancestral homelands and traditional territories of Indigenous peoples who have lived here for all of memory. The University of Washington acknowledges the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot nations. We offer our respect to their elders, both past and present, and honor their connections, past, present, and future to this land. We also acknowledge and pay respect to the enslaved peoples bought and sold into forced labor. We honor all the descendants of the victims and survivors of the transatlantic slave trade. We recognize the painful histories of white supremacy persist in present-day racial realities and privileges at this university and in our communities. We invite all to commit to dismantling racism and oppression by creating change where we live and work. Thank you for joining me in that acknowledgement. Before I introduce Dr. Bethell, there are just a few practical things I want to point out. We will have time for Q&A at the end of the presentation. Please use the Q&A box at the bottom of your screen to pose your questions to our presenter. Please don't ask your questions in the chat. We will be monitoring the Q&A box for questions for Dr. Bethell. Also, please type your questions as they come to you during the presentation, so they're all ready and queued up at the end. Use the chat function for any technical questions or problems that arise. Our team is monitoring the chat for those concerns. We are recording the lecture, and you'll get a copy of it or a link to it in a few days in an email. You're also going to get an email after the event with a feedback survey in it, and we really appreciate you filling out those feedback surveys because your feedback helps us plan our future events. Okay, with that, it is now my pleasure to introduce our speaker today, Dr. Christina Bethell. She's a professor at Johns Hopkins Bloomberg School of Public Health. She earned master's degrees in both business administration and public health at UC Berkeley, and her PhD at the University of Chicago. Dr. Bethell's work has catalyzed healthcare and public health transformation at the policy, systems, and practice levels, with a focus on whole person, whole family, and whole community models of care. Her work builds knowledge related to positive health development, social emotional well-being, and family and community health. She also advocates for policy reform and is currently advocating for positive health development, healing-centered, and trauma-informed approaches nationally and in state and local areas. Dr. Bethell has been a national leader in the development of policy, practice, and research applications of population health and systems performance measurement and family and community-centered improvement methods. We are very fortunate to have her here today presenting We Are the Medicine, Possibilities for Flourishing Through Difficult Times. Dr. Bethell, thank you for being here. We're really honored to have you. And with that, I'll turn this over to you.
Okay, thank you. Okay, here we go. Well, thank you everyone for being here on your afternoon, my evening. Oops, my video just went off. And I'm just going to go ahead and start my slides so that we can start sharing. I'm happy if people want to make comments in the chat too, even if we don't get to all of them, just because if you have reactions or expressions you want to share with the team, with other people and see each other's notes and ideas, I'm happy with that, but I guess we'll do the Q&A at the end. Okay, so let me start the slide. So yeah, my talk today is We Are the Medicine, Prioritizing Flourishing in Difficult Times. And the truth is that we're all in a lineage of people who've been through difficult times. We're the survivors, if you will, through a lineage of difficulties throughout all time. And some do better than others when we have difficult times. And we know that in that, we are the medicine, that when we look at what's going well or not well under different adversities, and we look at those that do better and not, often it's because we are what I call the inner and relational pharmacy has been at work. So we need each other in good ways. And we have capacities that we can all learn and are built for to heal. And so this is about calling that up and bringing that in very explicitly into our public health and our systems and our communities. I don't have any financial relationships to disclose. And really the opportunity for those of you, and many of you I know, know the science of healthy development. What is it that helps us develop as children and then all throughout life? And it's actually fairly new that we've articulated this science, life course health development, so that we come to understand how health happens and is continued and evolves and can grow. And this science really points to a lot of self, family, and community-led healing methods that need to be supported, but that we, again, are the medicine, but also that healing is prevention, because we're at a point of adversity when you measure it in society and suffering, that it's so ubiquitous that we have more of a syndemic, where it's bigger than an epidemic, right? And it can be self-perpetuating. So we actually really need to prioritize healing, not just for people that we think need it, but all of us, our entire collective is needing to heal together. So my goal is to just say a little bit about what I call the flourishing paradigm, to talk some about the science of positive childhood experiences, and then to begin to translate that in the short time we have to how we can catalyze what I call relational systems of care in policy, practice, and in the daily systems that we have. So in terms of the flourishing paradigm, it really sort of flips the narrative from toxic stress and trauma and adversity is the problem to relational health is the solution, and to looking at what the solutions are. So it's a proactive approach to promoting positive health, even in the midst of adversity. And some of you may know the World Health Organization has long defined health in terms of positive health and not just the absence of disease, but our systems don't really operate that way. They mostly look at how do we get rid of bad things, not how do we promote the good. Nor do they recognize that the absence of a disease does not equal well-being. So how many of you know somebody who doesn't have a health problem or a health condition but is not well? And that also it changes, that being flourishing, which we're going to define and talk about, and you get to reflect a little bit on your own, is a little bit like the weather. You know, it's like resilience. You know, it's stronger some days than other. It's contextually influenced. And so we need to think about flourishing and well-being as a living process that we engage with and are conscious about, just like we would eat well or sleep well or exercise, that we have to nurture intentionally our flourishing and well-being. So we typically define well-being in measurement when you see things out there like in the paper that say how many people are well, you know, or flourishing. And there's different ways it gets measured. And I'm talking about this in a very specific way. So I just want to briefly talk about the different ways you might have been accustomed to seeing it. So what I call flourishing of the remembering self is when you get asked, up till now in your life, how satisfied are you? And that's a very common question to try to measure well-being. But that's a reflection on your life up till now. It's not necessarily, you know, what's your holistic well-being. The flourishing of the experiencing self are questions that relate to, you know, in the last week, how often have you felt happy or emotionally well or had good feelings? And there's the flourishing of the requiring self, which is very important. And we often think of these as also social determinants, having food and housing and basic needs met. And then this is kind of what I focus on, which is the flourishing of the living and relating self, where we meet life in its all of its variation over time, the good, the bad, and stay engaged and stay in a sense of connection with each other, looking for the meaning and the promise, so that we can address the difficulties when they arise and otherwise celebrate our fortune. So this type of flourishing is called eudaimonic well-being. It's not hedonic well-being, which is do I get what I need? Do I have what I need? Am I happy? Which is not unimportant, but it's a specific type of flourishing, if you will, or well-being. This eudaimonic well-being is something we actually have a lot more control over in some ways. So I'm going to tell you more about what that is, but just give you a little data. It's not the prettiest slide, so forgive me, but there's a longitudinal study of adults in the country and looking at their well-being. And a study this last year came out looking at hedonic well-being, which are those first three components, and then eudaimonic well-being, which is much more the living and relating self, how we are in life, and whether we have a sense of meaning and purpose and so on. So about 23% of, or almost 24% of adults in America are estimated to have low on both. And about 15.7% are high eudaimonic, lots of sense of meaning and purpose and engagement in life, but don't really have a lot of hedonic well-being where they feel like their needs are necessarily met or that they're happy about their life, but they have meaning and they have purpose and those sorts of things. Somewhat high on both of them is about 27%, but really clearly mostly high. Still, there's not a lot of high, but mostly high hedonic and well-being is less than 20%, about 19%. So I think it's important to see that we are living in a society where potentially there's a lot of room for improvement for fostering our well-being and our flourishing, and that the rates are low enough that we know it's not just all about medical problems and getting rid of even adversities that we have, because so many people who lack any adversities are not in fact well in these ways that we're talking about. So there's a study specifically that looked at that on flourishing and assessing flourishing, which again, I'm going to define it, I promise, in 1 second and give you a chance to reflect on yourself. Looking at adults that had all kinds of different illnesses and those that controlled for that. And that when there was an absence of this flourishing quality, these flourishing qualities, death increased by as much as 62% over 10 years, regardless of all the other factors. So you could have a lot of diseases and they controlled for that. But it's the absence of the positive that actually is actually threatening life expectancy, not just the presence of what's wrong. So we haven't measured this very much, and we still don't practice measuring it. But if we did, I think we'd learn a lot. There's also a whole field called salutogenesis, which is the study of supporting well-being. It's been around for a long time. It's a conscious study to look at what promotes well-being and flourishing in the ways that we're starting to talk about right now. So one of the biggest predictors of well-being is this sense of coherence. And so I know that many people in your organization or in your community care about resilience and mindfulness and things like that. And it turns out that this sense of coherence is associated with a 30% reduced rate of mortality, so similar to the other study. And the sense of coherence is defined as having a sense-making, an ability to experience what you experience and make sense of it, in a way, making a positive, being in a positive relationship with your experience so that you can make meaning out of it and not feel victimized as much and out of control. The second is manageability or self-regulation, just in daily life, being able to regulate our stress response, which, as we know, when we have trauma, can be difficult to do, and we need to heal that. And then the last is meaningfulness, finding meaning and knowing that we find it. And it is there, but we have to look for it. And if we don't, sometimes we can be in contexts that don't bring that naturally. And living without a sense of meaning and purpose is one of the biggest predictors of all sorts of problems. And so it's very important that we own that. So there's lots of measures. These are some things. I'll share the slides later if you want to go read the papers on how these things are measured. But I wanted to go directly and ask for the poll to come up in a second. Eliza, I think you're going to put the poll up, that these are the aspects of flourishing that I think of as that living and relating self that I am hypothesizing are relationally enabled, that all of these aspects of flourishing are really hinging on a relational sensibility of seeing ourselves as part of our community, part of a family, that we belong, And then through that lens, we are able to flourish. So the first is a sense of meaning, which often involves something beyond yourself, right? Like the community, nature, other people, engagement with life and others, like staying engaged, participating. If there's a lot of people who participate a lot or a little, but being engaged in life, wanting to be in your days. Valuing and creating positive relationships. Not all of us are as lucky as others in having those relationships in our childhood. So we have to really work harder to find them sometimes in our lives, but being in the game, seeing that it's important and staying engaged and seeking relationships. And then having a positive orientation to life on purpose. Again, if it's not on purpose, it's easy for it to get washed away, but looking for the hope, the optimism, looking for strength, taking in the good when it does happen. And it's not necessarily what we've all been taught or wired for, so it can be hard. And this doesn't mean denying at all the difficulty. And in fact, it's really, they go alongside each other. They're on a dual continuum. And then seeking to contribute, whatever that is. It could be your smile, it could be anything, but knowing that you matter to other people, that you're not somebody who doesn't impact others, that if you think you don't impact others, so you remove yourself from things, in a way that does impact others. So we really are affected by each other, and we all matter to each other. And the last is a sense of inherent worth. And this is more of a sense of mattering just because. There's a lot of people who are, say, social workers or teachers or doctors who know that they're impacting other people and they matter in that way, mattering for others, but they don't necessarily maybe feel the innate sense I matter just because. Not because of what I do, but just because. And these are often feelings that get instilled in us through healthy attachment and our childhood. So when we have a lot of ACEs or trauma, this can be difficult and can drive a sense to contribute in a way that leads to burnout and overfunctioning. And that's actually really, really common among people who are in the helping profession. So what I wanted to do was ask you in the poll, if you could put it up, to just, setting aside that you may also have negative experiences at the same time, how many aspects of flourishing are you experiencing today? And then this slide, if you can see it, is listing those qualities out. So if you could just start it and for people to start answering it. And maybe Eliza, you can let me know when there's a good number and then just show the results on the screen if you can do that.
While we're pausing, I'll just say we've got 29 out of 49 responses, 32. It's going up. It's
okay, good.
Responding. It's
okay,
wonderful.
great. Keep responding. Yeah.
We're almost saturated.
And then we're gonna see, like, just for us here today, how are we doing? Like, just today, and it'd be different maybe in a week from now, but it's good to reflect. That's great.
It looks like almost everyone has responded now.
Okay, great.
Yeah.
Thank you. So Eliza, if you could show the results, that would be great. And so what we can see here is about 28% are experiencing all 6, and about 35% at least 5, and 35% 3 to 4, and about 3% 2 or less. And I've done this in different audiences, and this kind of distribution is common. And actually, this group is stronger in your flourishing, because 2 or less is actually more common, upwards of 25% in a lot of groups that I have spoken to and done this with. So that's how we're doing. So just take that in and reflect on that. And if we were in a room together, we could share about this. And I bet you people who are really good at meaning making and keeping connected could, we could support each other if we knew this. So I'm going to go, you can go ahead and close that, or I'll close it and I'm going to proceed, but I wanted to throw this into the space. So this was a more personal thing. Okay. So I was going to ask you, if we were in an interactive session, what proportion of children do you think are flourishing? So we spent a long time trying to figure out how to measure flourishing in children. In many ways, flourishing as adults is a developmental process that you evolve into a person who has these qualities. They can be taught or not taught. I think we're built for them, but if we don't have it modeled and we have a lot of adversity, we cannot even have a sense of these things being important or have the skills to create it for ourselves and work with each other. So when we look at children in the country, we look at being curious and interested in learning new things, which is actually something adults can see in a child, or having the capacity to stay calm and in control when faced with a normal daily challenge, being able to regulate emotions and behavior that in a way where it's small things don't lead to either a meltdown or a shutdown, that dysregulation response. And then persistence, when a child begins something that they chose to begin, do they persist, or if it doesn't go well, do they give up easily? Do we persist in goals to learn and stay in the game? So these three things together are represent a lot of different components of flourishing, and it's about 40% of children in the country actually have the data for Washington State. So I have some data for your state on all this data. And it's not as variable by public or private insurance, which is a code for income as well, as you might think. The differences in disease are much wider by income than the differences in flourishing. So there's a lot narrower of a bandwidth of variation in flourishing by these social determinants, if you will. And that's something we see over and over. And of course, the key for a lot of this is parental well-being and family well-being, and how we can, be resilient as families and stay together and practice resilient skills in a family. And we now have strong evidence that the stress of the mother really does affect the brain of a child that might come into life with less of an innate capacity to develop in ways that would lead to their own flourishing. So, the science is very strong, and I felt like I wasn't sure what this group all knew, but since it's a public group, I wanted to just make sure that you did understand, and probably do, that what gets in the way of flourishing, one of the big things, is childhood adversity. And these are really experiences that threaten the nurturing qualities of a relationship in a child's life. Safety, stability, but proactive nurturing and a sense of belonging and being seen. These are the experiences that really get underneath the skin in a positive way and help develop our well-being. And these experiences are threats to that because they threaten the relational context that we have and we feel unsafe. So you probably all know about this. And just to say, the research will continue on, I think, forever, but we have documented that the accumulated negative is what the impact is. So it's not necessarily this event or that event, or this one's worse than that one. It's the accumulated impact and the toxic stress that's the issue. And so it's important to know that, and they co-occur. So it's not like you can pull out one and say, well, this is the problem. And the study's been really clear. This is sort of a cumulative score of an index, this particular measure. And they go together, and some of the biggest symptoms are that we define with diagnoses and then give medicine for, have to do with qualities of being stuck on or stuck on off, or going in between the two, which are often, the outpicturing of trauma in our lives, along with many other physical symptoms. So we call those mental health problems, but they are very related to ACEs and the ability for a child to develop their stress response well and learn these flourishing skills. Negative attribution, sort of starting out early in life with a sense of, which children do anyway, kind of attributing what's wrong to themselves, a diminished sense of hope and expectations, which sort of cut flourishing off at the pass because you don't even allow yourself to dream. And we see this a lot right now in the mental health of our children and youth and population overall. So I'm just going to flash some data for Washington because I couldn't help myself. We just released the new national data less than a week ago. So for Washington State for 2022, which is the most recent data, according to ACEs, it impacts special healthcare needs status, with 44.5% meeting criteria for having a special need if they have 2 or more ACEs, which is actually an increase in the impact that from prior years. Having a mental, emotional, behavioral problem, 5.4 versus 32%. And this is just at 2 or more ACEs, which is where we really see the impact for kids. And then children who meet that flourishing criteria is 68%, which is still not perfect, but it's pretty high for no ACEs. But with 1 or more, it's 51, and then down to 28.3. So it's a big drop. And so this is a big threat to flourishing. And yet at the same time, there's a lot we can do to mitigate that threat. And there's a lot of variation in how children with ACEs do that has a lot to do with building family resilient, parent-child connection, communities of belonging, and schools that are safe and also belonging for children. So that's where we're headed. This is just another one that looks at bullying, a same pattern, having a mother that's in excellent or very good health. Obviously, that's very associated. And then families that stay hopeful in difficult times, which I would say 63% for those without any ACEs is still really low. We have a long way to go to build up hope in our society, to see it as the resource that it is and that we're built for it. And it's a relationally defined thing. I don't know how well we sprout hope on our own. And so this we are the medicine thing comes back in. But the levels of hope for children, only about 42% of children right now are, as of the recent data that we just released, are living in homes where families feel both hopeful and that they have strengths to draw on. And so that's going to really impact them, even if there's no ACEs on board. So we have a lot that we can be doing to build up. So again, not to belabor the point, but just not to wanting to ignore it either, so that when I go into the positive possibilities, we'll be very motivated, is that we do have a national emergency in children's mental health, that it's all of us, I call equally unequal, that at every level of household income, when ACEs are on board, the probability that child has a mental, emotional, behavioral problem is very high for all of us. So even though it's more likely that lower income homes have these adversities, once they're on board, they have a lot of similar impact in terms of health in one way or another. And in terms of flourishing, having these ACEs really is exactly the same across children in poverty versus children living in the highest income category of homes. Their flourishing is the same once they both experience ACEs. So I think that's important to recognize, that we really have a population issue, and that we all therefore should care and participate in the solution. So this study looked for the first time really at, because we didn't have all the data in one place to even look at it, these social and relational factors, and social determinants get a lot of play, and they should. And it's things like food insecurity and housing problems and neighborhood violence and experiences of racism in the community and economic hardship. And I'm calling those social health risks here. And then the relational health risks are having two or more ACEs, one or both caregivers who have poor or fair mental health. It's a pretty high bar. Really poor coping of families or parents. And when we have no social health risk and no relational health risk, the rate of mental, emotional, behavioral problems is 15.3%. And when we have no social health risks and two or more of those relational health risks, it goes up almost 3 times to 44.4. So even without the social health risks, we see a huge hit from those relational problems, which are really happening across the income spectrum. And again, I say this because we want to target to the greatest need, but we also want to address this at a population level. Of course, if you have both high levels of social risk and relational risk, the rates of mental, emotional, behavioral problems is 61%. There are school districts all over the country and in counties where that's the case. So we have to really kind of look at the data, and if everybody treating a child with or supporting a child in their mental well-being understood these relationships, they would understand that we have to work together in a system, that we can't just go over here and deal with a mental health problem and then go over here and deal with a food insecurity problem. We know that helping people who have social needs like food insecurity can be difficult, actually. It can be difficult to get the resources to them, or for them to get to the resources, even with help. And there's got to be a way that we look at people holistically and help them across systems in a systems approach. So all to say, this is the end of the what's the problem and getting to the solution. Again, I started with the solution, now I'm getting into the problem, now I'm going back to the solution, which is to say that eliminating risk is not enough. I really want to open this next section by saying that children without any of the risks I just talked about, social or relational, are still 71% less likely to demonstrate that quality of resilience that's so important to school readiness and school engagement if they lack strong parent-child connection. So the absence of the positive at every level of adversity is the problem and is a huge part of the problem and is a huge part of the solution. And the CDC study from April reaffirmed that, and they asked youth about their context and how many had mental health problems and anxiety. And again, relational health popped out, that being close to somebody in person at school that you knew, not just over social media and that kind of thing, really led to a very big difference in the prevalence of poor mental health. So we keep seeing this pop up, and again, it's a good news story because we can do something about it, but we're not practiced really, and our systems are not necessarily set up to make that happen. So let's look at the rest of our time at the possibilities of flourishing and some of the research. So back in World War II, the resilience research started, and I love Ann Maston, this Ordinary Magic book, because it really is ordinary magic, right? It's like we're built for it, but we therefore sometimes think, oh, well, it's happening, right? We're all, tending to our relationships, but if we're not intending it, it's probably not happening. And then it explains a lot. So relationships, teaching the child their own relationship with themselves, their capacity to be connected, to reach out for help when they need it. And then the community relationships are really very evidence-based, going back a long time, explaining the difference in how people how people fare, even when they have similar levels of adversity. And our first big study on this looked at everything we could find on what might be a positive protective factor. And basically, these are all lined up right here, and you can see the different effects on the probability of flourishing for children. And the parent and child connection stood out the highest. Family, knowing that they have strength to draw on difficult times, so that sense of family hope and those sorts of things are also very impactful. And then, but parents participating in child activities is protective, but not nearly as protective as the relational pieces and the sense of hope and strength. Oops, sorry about that. But the bottom line is that there's no magic bullet, that it's really, again, just like the cumulative negative for ACEs, this is the cumulative positive. So you can't really go wrong. For some children, it's community, school, and adults outside the home that are the main support system. And the more, the better. And that there's all kinds of ways that we can build it. So it operates just like ACEs, and we didn't know that. So we've created the positive, cumulative positive indicator, the positive childhood experiences to the ACEs. And then we were curious, of course, about that and what it looked like. So I'm going to get to that in a second. So the first thing we did in this trajectory of curiosity about how we can promote the positive as a way to mitigate the negative and create flourishing as the outcome, so the positive health, was to, don't worry too much about the graphs, but the bottom line is that even for children with 0 ACEs, which is that blue line you're looking at, when they had fewer of the family resilience and parent-child connection factors, they were much less likely to flourish, those flourishing qualities, than if they had more. So at every level, but if you have 4 or more ACEs down here, it's still almost 3 times higher that you're flourishing if you have more family resilience and connection factors. So we should be doing something about that, but it's of course lower, but the relationship is the same. So whether you have these risks or not, it's again the absence of that positive that ends up being the problem. And similarly, a newer study on kids with mental health problems showed the same thing, that at lower levels of parent-child connection, children were a lot less likely to exhibit resilience and self-regulation at every level of adversity, social and relational. And that why this matters, if you need to talk to legislators or a lot of people who care about the population and the economy, which is often the argument you have to make, is this is a direct shot at school engagement and school readiness. And we have a lot more data on that. But if we look here at children who have high resilience and self-regulation at every level of adversity, this is their engagement in school when that self-regulation and resilience is high. When it's low, this is their level of engagement in school, 17.8% to 26% across those levels of risk. So it really is, again, like an equal opportunity issue. At every level of risk, we're seeing a huge impact. And so hopefully we're very compelled. So some of you may have heard this concept of positive childhood experiences. I've been leading up to it. We formally looked at 7 qualities or 7 factors that were sort of evidence-based on their own, and wanted to include them in a survey of, it was a Burfus survey, if you're familiar with that, where we also had ACEs and health status and health behaviors and mental health problems and everything like that. And the 7 positive experiences were asking adults to look back on their life, just like they do on ACEs, on feeling able to talk to your family about your feelings, feeling your family stood by you during difficult times. And you'll notice I'm saying feeling. I'm not saying if a helicopter came in and decided that you had it, you had it. Did you experience it? So this is where we can't get away from experience. It's about experience and enjoying and participating in community events. So asking, were there events in the community, isn't really quite it. It's, did you enjoy it? Did you enjoy participating in it? Did you enjoy doing these things? So it's very important that we understand it's about the lived experience, and that's what's knocking around in our nervous system our whole lives that is having the positive impact, is that experience. So feeling a sense of belonging, not that you were so popular, but you just walked in, you feel like you belong. It's a really vivid feeling, like I belong here, and so on. And so our findings were basically that when people reported more positive childhood experiences, they were much less likely, 72% less likely, to also have had depression as an adult. And in terms of their own social support as an adult, which is something else we also looked at, they were 350 times more likely to have positive social, emotional support that they needed as an adult when they had more of these positive childhood experiences at every level of ACEs. So it's again showing, and this is a population-based study, that really, you know, in many ways sort of drives home what should be obvious, but it's not obvious. And it gives us a sense of the possibilities. And again, even without ACEs and even without high levels of adversity, the absence of the positive really is associated with the negative outcomes that we want to avoid. But more importantly, it's associated with the absence of flourishing, the absence of the positive health, which is flourishing, not just not having the disease. So the American Academy of Pediatrics has flipped their own toxic stress statement. We worked with them through some of the research I've been sharing with you. They formally come out to talk about relational health as the solution, partly based on some of the research I've shared with you. And so their work now is really on promoting relational health through primary care and in pediatrics and with the community. So good news is I think you've all been up to it long before that. But there's a paradox, and I think it's important to understand the paradox, which is that when you talk to people about their positive experiences and you look at those positive childhood experiences that we looked at, often it's how we're met when things are hard that ends up being the most positive experience that we have. So we can talk about, you know, merry-go-rounds and carnivals and those kind of happy things in childhood, and that's not bad. But it's really what sticks out is when things were hard, I had someone who cared, who saw me, who connected with me, who looked at me like I mattered, who stuck through with me. I knew I could count on them. So we are built for that. We're social creatures. We don't, I think, give ourselves the power that really own the power that we have, and also give ourselves the vulnerability that we need each other. And without those in place, we will miss all the opportunities. But this is a study that just showed that addressing and being at the watch of negative emotions, so that then you can be aware that you need support, is actually a positive thing. That when we have a habitual acceptance of our mental and emotional experiences that are negative and that are needing our attention, it does not lower our positive emotion, and it does lower the negative. So it's very important to see in research even that it's not dangerous to address our negativity and our trauma if we do it in a way that's, you know, in connection with others and for the purpose of healing and not just repeating, right? So we know that. So I wanted to just let you know there are studies out there. Also, disclosing trauma just through writing in a journal has been associated with improved immune function. And we know that our experiences of trauma, which are in many ways the absence of those nurturing relationships, right? That's in how we look at ACEs. So there's things that we can do by sharing about the very things that are hard that really actually lead to the hope, well-being, and flourishing that we need. But it requires vulnerability and connection. Unfortunately, there's a lot of young people who are not responsive to opportunities and resources for support. And I think you're probably aware of this. In Baltimore, there's an underuse of youth mental health services, which is very difficult because we think we need more, but because we have a lot of kids in need. On the other hand, there's also an underuse or a lack of follow through. And so how do we really engage and build those trusting relationships with all people so that when help is needed, there's receptivity to that? Because often the people who might need the most help are not necessarily seeking it, or if they are, it's hard to engage. And so we have to be those people, us, ourselves, to build that sense of connection and safety with everyone we come in contact with who we hope to help. And so there's studies really showing that when a youth has a problem, like say is needing some counseling or support or is having emotional difficulties, it's not that they don't want help. There's shame. There's a sense of I'm going to be stigmatized. And so the catch-22 here is that if there's not experiences of it being accepted in the times when things are hard for you in your past, it can instill just an assumption of stigmatization, whether or not that's what you would have actually experienced if you reached out for help. So the mattering is the key, a sense that I matter and that I'm not going to be stigmatized. And that's something that really, I think, needs to be lifted up at a community level so that it's literally in the water system, it's in the air. And so that people who've been kind of maybe stuck in not even reaching out for help or having a hard time, following through to get support, start to build their own sense that it's safe, that they belong, that they matter. And so at a community level and at a relational level, it's very important. So this study is really saying, again, that it's feelings of not mattering that are associated with the fear of being stigmatized when you're going to seek help. It's not necessarily that you will be stigmatized. It's the fear, and then it's internalized to the point where you don't reach out. So really increasing a sense of community mattering and belonging, I think, is really key. So this is just, actually, I'm not going to go through all this, but this is just to say that mattering plays out in the community, work, relationships, and within your own self. And that feeling valued by others just because of who you are is very different than adding value. The kind of mattering, like I add value. This right-hand part of the diagram is the part we usually do better at. And the left-hand part is where we're really seeing the associations with poor health. Okay, so I'm going to start to close with really just that going back to the beginning of how we are the medicine. And that literally means you and me every moment. And, that requires presence and mindfulness, also a lot of self-compassion because we can't always be present. But your well-being is really key. Your being is very important to helping the well-being of those in your life, right? So there's this quote I love called "The intervention depends on the interior condition of the interveners." And this idea that every interaction creates a reaction. Right now, our nervous systems and brains are regulating each other from moment to moment. And that, we can't just ignore that living process of relating in a pretty present, embodied way. And those are skills that we can learn that have a lot to do with creating a sense of belonging and mattering and safety in our world. So if you're a person who interacts with children and families, or if you're a person at all, it's very important to understand how important we all are every moment to each other, whether it's a stranger or someone you know. And for those of you who are interested in the research, lots of studies have gone on about trauma-informed care and healing. And ultimately, it all comes back to the relationships that we create a sense of mattering and trust with patients, but also for people to see how we're treating each other. So if you have a clinic or a community organization and a youth comes in and they see people not being nice to each other, that sends all the information they need about whether they're going to be safe. And so we really, can't really get away with just caring about the patient or caring about the one we're serving and not caring about each other. So again, it's a pretty big high call to action, but this research was very clear to show that how teams are with each other has a big impact on their ability to engage and support those that they're trying to support. This is just, I really want to make sure I leave you with this paper, which I'll send the slides. There actually are definitions of a healing relationship, and we can learn it. And it has to do with things like valuing, and how does feeling that you feel the person feels valued, what is happening when they feel valued? They feel that sense of presence, which is a thing that we can define and learn. They feel the connection. There's a sense of appreciating power and really acknowledging power dynamics and honoring people as partners, and really dismantling all of those habits of power differentials and so on and so forth. And then abiding, feeling like you're really sticking it out with people. So in any case, there's definitions of this that we can talk about. And probably underneath so much of it is what comes the most naturally if we really tap into what we're built for, is this sense of compassion and empathy. And for the studies, you have to study this, that 40 seconds of, if conscious communication of empathy and kindness to a patient leads to marked anxiety reductions, also looking at fMRIs in brains. And so just having compassion for the lived experience of another person, even if you can't fix it, to go from fixing to connecting, has a very powerful impact. And when we explain like why some people get better than others after surgeries, there's a whole book called Compassionomics that documents all the research showing the connection between how we are and then how we relate to each other, and that does with our neurobiology and how that is connected to well-being. So we have a lot of power if you're in a position where you're working with other people, but also it's so stressful. So burnout is really common. And this little diagram to the right is showing heart rate variability for people when they're in a place of connection and appreciation and compassion versus when they're not. So putting myself in a conscious space of empathy and compassion for another helps regulate my heart rate variability. So it helps my physical well-being and helps us stay out of burnout, because we're with others in the suffering. We're not necessarily taking responsibility to fix it, which is a whole nother thing. So overcare or undercare really lead to burnout, but just presence and care can actually, keep us all well. And the withholding of that is very, very, very damaging. So there's some research I just wanted you to know about. And finally, the last piece is building systems of care that embody these principles, right? And I think you're an organization, the Washington State Child and Family Wellbeing Center is working really hard to go from this trauma organized society that we're waking up to. It's pretty shocking when we really see how deeply we have been organized to create trauma and systemic racism and all of the things, and we're embracing what's possible, moving toward a healing and flourishing centered possibility. But to do that, we have to choose it. So we know that we, start with our functioning, and things happen. Lots of things are happening today, and in the environment and the fires and the politics and just the threat of life. And that will always take its shot at our nervous systems and our emotions and our hope. We are going to be impacted by that. And then there's a way we can recover using, some of our skills, or we know the possibility to actually grow and to come out better. And that takes a commitment, a choice to do that. And it takes purposing, being on purpose with each other, but also care for each other. We really can't do this by ourselves, but it does require a choice. And it's a different kind of resilience that we're talking about than that bounce back kind of resilience, which really means that we may not have had a lot of resilience to begin with. So what does bounce back mean? So the idea of radical resilience comes in. I'm just going to show this and give you the point of it. But many of you might be already here, which is when we're resisting disorder or resisting change or numbing off in the various ways we do, walling off, protecting, trying not to feel, that becomes a source of stress. And that we're unresilient, fragile. We're very fragile in that place, anti-agile, we're protecting. That is not resilience. Robust maintaining, managing the stress, compartmentalizing, controlling it. is better, but that's still not really the kind of resilience we're talking about that's really living and relating. Then there's being agile, adaptive, having a lot more capacity, and these things get built over time that we can learn. Kind of knowing that life is always going to have ups and downs, that we can learn, we can reach out to each other and use our resources. And then there's more of a radical sort of evolution of this, that is a level of resilience that actually embraces disorder, because if we look, we almost never go a day or so without it being there. Instead of labeling that as it's wrong and it's bad and I need to fix it, this is kind of what life seems to be. And so how do we bring that flourishing and the living and relating self to that in a space of creativity and connection moment by moment with each other? And that's sort of ultimately kind of where I think we can go together if we choose it. But that means we look at our mental models, we look at our relationships, and then we can come in and change our systems. Trying to change our systems and policies and resource flows and standards of care and how we do things around here is often where we start in community translating to policy, but it usually fails if it's not sitting on a base of connections and relationships and a sense of respect and safety with each other. Power dynamics where everyone feels they matter and belong, because when a group doesn't feel that way, it will eventually undermine progress and also isn't okay. And all of that sits on the mental model. So spending a lot of time down at this implicit level of what are our mindsets, what are our beliefs, working on our relationships can pay huge dividends if we're going to actually create the conditions for systems change that we want to. So that's sort of my talk. I'm going to not say all of this, but I will leave you with a poem. This is just a picture of a young man who did art and went from this beautiful young boy to using art when he had had a lot of trauma, getting in touch with the trauma, what he did to mask it, and then through processes of art, music, and relationship and being listened to, really felt he found his essence so he could start to restore and move out of the deep pain and lack of wanting to live that he was experiencing. So these were just some pieces I was going to share a little bit more with you, but I spent too much time on earlier slides. But mostly it's just that we have so many possibilities to peer into what's inside and teach our children and teach ourselves the skills that we need. This was somebody called Sweet Pea who went through a lot, who had 8 ACEs and went through a lot of processes, including deep work around mindfulness and being able to talk about feelings. And she came out writing this amazing poem about her understanding and the transformation that she went through. So her poem is called Only Begins, and it goes, I am in the world and the world is in me, from my toes to my nose, to my belly to my knees. What's in is out, what's out is in. Endings can't be ending because there's only begins. And I guess that's what she called mindfulness when she explained it to me. And begins are like flowers that lean toward the light. When I'm aware of what is there, it's never really night. The scariest of scaries are just frights from before. I'm almost never afraid of what's actually at my door. So anyway, I really am going to stop because I realize I'm running out of time, but she explained how every stanza related to the process of learning, to acknowledge experience, to reach out for help, to practice skills, and then we can start to move beyond the trauma and into flourishing as a possibility for all of us and for all of our children and families. So I'm going to leave on an optimistic note that healing is upon us because it's within and between us. And we got the research to show it. So thank you.
Thank you so much, Christina. I know that if we were in an auditorium, we'd be giving you a cheer. Thank you for that lovely presentation. I really appreciate you sharing your valuable critical work and this perspective that takes us out of the ACEs perspective and brings us to, I love the term that you used, radical resilience. Along the way, I was thinking about radical acceptance. A few times we talk about accepting the negative and sitting with it and recognizing it as part of them, what can lead to the change, which is the radical acceptance idea. So I really appreciate your radical resilience.
Yeah.
comment. We had a couple of questions in the chat and the Q&A asking for
Okay.
books that you might recommend.
Mm,
So we'll email those to you.
okay.
One is, just applying some of these concepts more on an individual level and for youth.
Okay.
And
I
if you
can
have
tell
any,
you there's one book that just came out that I was involved with called Girls on the Brink. And it really is relevant for all youth and all of us, but it's really a take on what we can do to support the mental health and well-being of all of our girls and of course all of our boys through many of the positive experiences and practices and things like that. But I can send you a little list of books. Okay.
that's great. Well, I'm
Mhm.
included in the email that goes out. Thank you both for your questions about books. And I was, as you're presenting, I know you asked us to spend time on the mental model before we start talking about systems and policies and changes like that. And so I recognize that as critically important, but I wonder if you have any initial thoughts or highlights. And I'm thinking more like at community level and systems level, how we engender and support and sustain these critical relationships that lead to flourishing. Because often we have these intergenerational assaults that challenge those relationships, and so how can we create the communities and systems that sustain them?
Well, it's not to say that you don't start collaborative discussions with a discussion about tactics and where you want to end up. It's just that as you do that, you need to make sure that you're tending to where people are coming from. So you use the process itself to build that, and then, kind of the change happens. So one area that I focus on a lot is optimizing the systems we already have in place. One of those systems is the primary care system and the school system. And we actually have, for example, well child visits are paid for every child, and only about half of them are happening. And that's the place where already in the AP guidelines, the goal is to really look at the whole child and family and support relational health as a top priority. And to do that in the context of all the other things going on. And so we can optimize those. And so a lot of my work has been on creating ways to engage families as partners and drivers of high quality preventive services that are very linked to community-based supports, because so much of what is needed, and parents maybe or youth and others who need more supports with either ACEs or learning some of these skills, would have a place to go. So integrated systems of care for primary care and prevention, I think, is a very high leverage opportunity. And bringing people together that already have that responsibility. For example, state agencies, I've done an analysis of all the state agencies, and they all have a statutory responsibility to make sure that there's developmental screening and social determinant screening. Everyone's supposed to do it, but we're not working together. And so that's one way. The other is really at the policy level of looking at Medicaid and managed care organizations, which are required, for example, to ensure high quality preventive services for all kids based on Bright Futures guidelines, which include a big focus on relational health. And they're required to do it, and they get paid to do it, and they're held accountable for it, but it's not really happening because there's not enough of a focus on it. There's not enough of demand for it, even by the patients, the families. So if families get activated and Medicaid and health plans can kind of make an intention, we can start to really create a system where there's the incentives, the guidelines, and the demand for it. And I think really start to help early in life to get up underneath the trajectory of intergenerational transmission. So that's one way.
Yeah, that's a complicated way. Getting all those systems integrating and working together feels like a huge challenge, but it's definitely an effort that I hear a lot happening.
Well, I mean, the bottom line, though, is to just even educate families and activate them on what is available for them and what's, and for them to come in differently and start to access resources and supports that are already there. It will start to change the system. So the bottom up or grassroots change is a very powerful thing, I think, too.
That's great. So we can get more information out to families and
absolutely
help change the system. That's great. Well, we're at time. Thank you for sharing your excellent work and perspectives and wisdom with us this afternoon.
Absolutely.